Welcome to AETCM, the Emergency Medicine channel. Myself, Dr. Naveen Mohan, HOD of Emergency Medicine at AIMS Kochi.
I'm Dr. Jerin Varghese. I'm final year resident.
Dr. Shreya, first year resident. Dr. Cecil, first year resident.
So today we are going to present a case about a 41-year-old female who came to her ER with complaints of abdominal pain since the past one day associated with constipation and urinary retention. Shall we move on to the primary survey, sir?
Yes.
So in primary survey, in initial 10-second assessment, patient was conscious and oriented, and in the airway was patent and there was no pooling of secretion. In the breathing, air entry was bilaterally equal with respiratory rate of 20 per minute and saturation of 98% maintained in room air. In circulation, her pulse rate was 100 per minute with BP of 110/70 mmHg and all peripheral pulses were palpable.
CRT?
CRT was less than 2 seconds, sir. In disability, her GCS was full score and her GRBS was 110 milligram per deciliter. In the exposure as such was done.
No lateralizing signs?
No lateralizing sign was noted, sir. And further, we have done the IV cannulation for a pain, and we have given him here initially IV paracetamol was given and blood was drawn, sir, in the circulation part. And from there itself we have took the CBC point of care. And CBC point of care, initial point of care was showing a total count of 7,000 with platelet count of 2 lakh and HB of 15 with CRP of 3.
Why did you draw CBC CRP point of care?
Abdominal pain, sir. Abdominal pain was present.
So why in
parameters,
primary
any
survey?
UTIs. The initial we will always put the cannula, sir, and circulation, but so that time we drew the blood.
Okay.
We got the report.
So primary
later,
survey
sir.
wise, patient is stable. Only thing like it came with abdominal pain and
Constipation, urinary retention.
Urinary retention. Okay. So we are not going further into the detailed aspects of primary survey. We'll just skip that part because we already know what all things to do. Look in primary survey. Okay.
Coming to the sample history, she is a known case of hypothyroidism.
41 years.
41-year-old female. Known case of hypothyroidism for the past 2 years on tap thyronome 75 microgram.
Okay.
So coming to the further personal history, so she is a she is P2L2, parity is 2, live birth child 2.
Why did you start with this thing? Past history first?
Past history, she is past history.
Normally we'll start with abdominal pain. The chief complaint is abdominal pain. So it will be like the chief complaint has history of personal complaint.
Okay, sir.
Past history, it will be like that, no?
Past history means she is a status post.
Or else if it is going according to this thing, primary survey, secondary survey pattern, it should be ample. The ample history.
Allergic history as such, there is no allergic history. Then medications on thyronome. Then past history, so history of status post laparoscopic sterilization that was done 12 years back. So now she presented with so last meal was early morning. So now she presented with complaints of abdominal pain since one day associated with constipation and not able to pass urine since morning. So there was no history of any bleeding per vaginum, fever or nausea and vomiting.
Why did you go in that way? Like you should elaborate on the history of personal complaint. The abdominal pain.
Yeah, sir.
So this one you are talking about the negative history.
Negative history. Fever, nausea, vomiting, bleeding per vagina. Negative history was.
Why like went in that bleeding per vagina and all? Why did?
Sir, that multiple differential diagnosis as such for
abdominal pain.
pain.
For the time being, abdominal pain is a gross. It can be anything. Could be because of gastritis, esophagitis. Sorry, gastritis, pancreatitis, as BP,
Yeah.
then appendicitis, ureteric colic. Right. Then what else? What else?
So-
Abdominal aortic aneurysm. Abdominal aortic aneurysm rupture. It can be anything. Some gynecological, pelvic inflammatory disease. Ectopic pregnancy.
Yes. So,
So, based on your HOPC only, we'll get to know what exactly is going on.
sir. Her onset of pain was in the early morning. Onset duration was since morning the patient is having the pain, and
Where is the pain?
abdominal pain, which is more. She is complaining of like
Well, if it
wall
is
of the
abdominal
abdomen.
pain, your history should be Socrates. Site, onset, character, radiation, associated symptoms, timing, exacerbating relieving factors, severity. And then you should be addressing all the other 8 systems, questions pertaining to the 8 systems of the body to come to a final diagnosis.
So, as she was not able to correctly point out a site, wall diffuse abdominal pain she was telling. So, onset was from morning. Then
After PCM, pain subsided or?
pain got reduced, but not completely relieved.
All right.
So, then no, actually no radiation of pain
So
was not.
what is the Socrates of the abdominal pain?
Site is abdomen.
Diffuse abdominal pain.
Onset is early morning. Then radiation.
Sudden onset.
Sudden
gradual
onset. A kind of sudden onset progressive pain.
So early morning she was simply lying on
Bed.
what was she doing that point of time?
She was on bed, sir. With the pain, she woke up.
With the pain she woke up. Okay. Sudden onset pain.
At that time, she woke
Gradual,
up.
she
with
woke
the
up
pain.
because of the pain and it gradually progressed.
Progress.
So what is the character?
Character also she was not correctly able to tell, but kind of colicky pain, I think some.
Diffuse abdominal
Diffuse abdominal pain.
pain. Radiation.
Radiation, as such, there was no radiation when we are asking. No shoulder pain was noted, sir.
Okay. Back
Pain,
to the
shoulder
back.
pain. No pain.
To the groin, loin.
No,
groin.
no pain, sir.
No.
So then radiation, then
Timing? When is it started
from
in the morning? It was progressive.
progressive pain, sir.
When did she present to our ER?
By afternoon, evening, 3 p.m.
It has been from morning onwards she was staying there with the pain. Didn't go to any other hospital.
Local hospital.
Went there. Okay. And they gave
Painkiller, analgesic, and
further any investigations done there?
no investigation done.
Anything which exacerbates the pain or relieves the pain?
She was complaining of pain during movement, increased pain during movement.
Movement.
As such, when she is trying to get up or sit, she was complaining of pain.
Relieving factor?
Painkillers, NSAIDs.
No other relieving
other
factor.
relieving
Positional variation and all.
Pain was there.
On stooping forwards.
She can't sit up, like she doesn't want to change her position.
Because of pain.
Changing
She doesn't want to
makes
change her
her
position.
Pain, makes her pain.
Okay. Lying down, is it getting aggravated?
She is lying down.
Still, she's comfortable without movement.
Still lying down, like.
Still lying down, she's okay.
She's
Not
comfortable.
propped up, still flat.
So pancreatitis is
One of the DDs.
it should aggravate, no?
No,
Lying down, pain should aggravate it in pancreatitis.
Stooping should relieve.
Stooping should relieve, but this is not going with pancreatitis.
She's not able to stoop.
but she was not able to move at all. So
Still, he's lying still because of the pain. So, what is the severity? Like,
severity as such initially on pain scale we got when we initially asked, she was telling a pain of 8 out of 10, which got relieved up to 5 or 6 out of 10 post PCM, but still the pain was persisting.
then associated symptoms.
Associated symptoms, the constipation and urinary retention was there.
So, your GIT, questions pertaining to this GIT?
Nausea, vomiting is not there, sir.
Not there.
Not there.
Okay. Nausea, vomiting is seen in which all cases?
Then in
With
case
abdominal pain with nausea, vomiting?
Gastritis.
MI, even MI, if it is a cardiac ACS also can cause abdominal pain with this thing.
Then intestinal obstruction,
Gastritis is a okay. Pancreatitis,
pancreatitis,
intestinal obstruction, DK, yes, DK can present. That is a medical cause. Okay. Then UTI,
Cholecystitis.
cholecystitis, pyelonephritis, abdominal aortic
nausea, vomiting will be
no rupture, capillary rupture,
that differential diagnosis.
ovarian torsion can present with ectopic pregnancy.
Yes.
Then
So
PID,
pelvic inflammatory disease can also as a differential diagnosis, sir.
okay. Many differentials are there. Like so, in GIT questions will be vomiting, nausea, and any loose stools.
Stool bar
Your patient had constipation. So intestinal obstruction, yes, it wasn't. Was it obstipation or constipation?
Like when we constipation, but when we use no absent bowel sounds were noted, sir.
Pardon?
Absent bowel sounds were noted.
They're not there.
Was noted, sir. Was
Was
noted.
noted. Okay. So at this point, you're suspecting intestinal
Intestinal
obstruction. Genitourinary, any issues, any dysuria?
No dysuria noted, sir. No dysuria.
Any change in urine color or
No change in urine
any
color.
change in urine output?
No. Urine output was urinary retention was there.
Urine retention was there. Okay.
Sir, then coming to the other systems, CVS, there was like all pulses were as primary survey was completed, no complaints
History
from
there. History pertaining to the CVS.
CVS. There no history of any.
Grossly we can just cover.
Normal, sir. As
No
soon as
chest
two
pain,
head,
no
no chest pain, no murmur,
no dizziness.
no other complaints, sir.
Murmur and all will be
Cardiac.
on examination wise only.
Then
CVS RS, no breathlessness.
no breathlessness. CNS also
No
was,
palpitation. CNS
within normal limits, sir.
had urinary retention,
Urinary retention was there.
abdominal pain, but no weakness.
No weakness. Complaining of abdominal pain was the main complaint, sir.
Body pain, muscle pain, musculoskeletal loss, also no issues.
No other issues, sir.
Pertaining to the history, like history. Okay.
Then further we'll
GIT then skin.
no other complaints.
Skin is all fine. Miscellaneous any fever, lymphadenopathy, any lymph nodes, any swelling,
No,
nothing, weight loss,
no weight loss. Actually, she is a little obese patient.
obese. That's about your HOPC.
HOPC, sir.
So at the end of your HOPC, what are your differentials?
Differential diagnosis: patient was complaining of abdominal pain with constipation and
41-year-old, hypothyroid,
hypothyroid
pain
patient.
with abdominal pain, urinary retention, constipation,
Constipation.
diffuse abdominal pain. So DDs,
So appendicitis.
obstipation, right?
Yeah.
So intestinal obstruction
Intestinal obstruction is DD.
is your DD at the end of. Correct, no? No history to suggest pancreatitis, pyelonephritis, UTI, nothing.
That will be the other DDs which will be having very less chance to.
Okay, based on your history, it's intestinal.
Sir, other history, obstetric history is set to obstetric history. I will tell, sir. Obstetric history.
The past history you tell. Past history you already told it patient is hypothyroid and also some
Status post sterilization.
sterilization.
12 years ago. So,
Okay. Sterilization means it's an intra-abdominal this thing procedure which is done.
so laparoscopic
chances-
sterilization.
okay. So chances of ectopic pregnancy is there.
Yes, sir.
Okay.
So, in the menstrual history, so she was having a regular menstrual cycles and
Menarche.
LMB was like 6 weeks back. Last LMB. So she is
Mental history
having
should start with menarche. The entire history, menarche, how was it going on, was it regular?
regular from
How
12
many
years of age she started, and it was regular.
regular? How many days each period last? How many pads should be
So
changed?
usually her periods are like 28 days and changing 3 parts per day, and no abnormal history of any excessive bleeding, and so other history is like married since last 17 years. Parity is P2L2 with the previous 2 full-time normal delivery. Last childbirth was 14 years back and followed by sterilization. That was done 12 years back.
Okay.
So the other thing that we got from the history is that amenorrhea for the first 6 weeks are.
All right.
So,
So then ectopic pregnancy will again come. Like
yes, sir.
one DD is intestinal obstruction, other one is ectopic pregnancy.
Ectopic pregnancy.
Okay.
Then the other DDs which are really less significant, like
Past
abdominal.
surgical history, this is the only that's the only surgery which is done.
No
Okay.
other surgery was done. And patient can have other DDs like any ovarian torsions, cholecystitis, pancreatitis, UTI, pelvic inflammatory disease, or any pregnancy or abortion because of the amenorrhea, inflammatory bowel disease. But these are having very less chance considered to the
Based
intestinal
on history,
obstruction.
it is not suggestive of
Yeah.
based on the kind of pain you told, the vomiting, the postural variation, it's not suggestive of pancreatitis, nor is
Pancreatitis.
it suggestive of cholecystitis.
Cholecystitis.
It's a diffuse pain. Normally, cholecystitis should be right hypochondral pain. Pancreatitis should be epigastric pain. Like ureteric colic should be a flank pain,
Sir.
lumbar area, right? But this is a
Diffuse pain, sir.
pain. All right.
Sir,
Not even hypogastric. Hypogastric, so propubic area was all.
she was telling us diffuse pain, but on palpation we got the pain like tenderness over the epigastric region, right lumbar and right iliac fossa, sir.
One thing which is unexplained is patient has not passed urine. Urinary retention. Why so? With a history of
So
abdominal
by
pain.
at that time, so we was having the most probable DD of
Retention
intestinal
means
obstruction.
either the bladder will be full and patient wants to urinate but it's not unable
Yeah.
to pass.
Yes.
In a female, it is a bit difficult to explain. Males, you can explain prostate and all.
So that was the main cause for the DD of intestinal obstruction which
Or whether it is AKI. Whether it's urinary retention or whether it is AKI is the next question. What about yeah, continue.
further we had done all the labs, sir. So can we continue with the further examination?
continue.
So abdominal palpation, as such we got the tenderness over the epigastric region, right lumbar and right iliac fossa. Other examination as such was
Tenderness here, right sided.
right sided tenderness, sir.
History wise, it is diffuse, but palpation wise, it's right sided.
Yes, sir.
What happened right sided? Appendicitis.
Yes, sir. That was one of the DDs.
Okay.
So other
Or it could be a right sided this thing. What? Ovarian torsion.
ovarian torsion can also be a DD, sir.
Right side abdominal pain with vomiting. Ovarian torsion is one diagnosis which shouldn't be missed. Then again, ectopic pregnancy.
Ectopic pregnancy.
Okay.
So further we went ahead with
Ureteric
ureterical
colic also can
But,
cause vomiting.
And urinary retention also.
But that should be a loin to groin pain. But this was a diffuse pain which she complained of. It was not a colicky type.
Yes.
All right.
So we did send our routine further investigations, and also for
Abdominal examination only that.
that was the significant finding noted, sir. Other systems was also within normal limit. We send all the routine.
Ideally, you should be doing a pervaginal examination also. Because she's a female, you should do a genital area. You should see pervaginal examination. That is one station you will get for a Marka Mosque. Do a PV examination, probably like Last time when I wrote my MRChem, I had a this thing, a condom stuck inside the vagina. Take it out. You'll have to do the procedure, explain and do the procedure as such on a dummy. Okay.
Okay, sir.
All right. Done?
So further we sent the investigations and did a USG abdomen, sir. Here. So USG abdomen was like
What about
was
the
known.
lab and all? CBCRP?
CBC initial point of care done, sir, which was showing a total count of 7,000 with the platelet count of 2 lakh and HB of 15, CRP of 3, sir.
No infection.
No infection.
So pelvic inflammatory diseases
Is ruled out, sir.
ruled out. No infection. Okay.
Sir,
Patient, his sexual history. You didn't mention about the sexual history.
sir,
The kind of the sexual habits
uh,
that they have, whether it's a previous history of some IUD or oral contraceptive pills and all these things. Whether it was
so
there.
she was not taking any OCP bar IUD, and she was asked, she had status post laparoscopic sterilization 12 years back by Fallopring, sir. So sexual history as such, when we asked
What
about
was the last sexual activity?
actually we hadn't actually asked like that, but when we asked any chance of any pregnancy, she told there is no chance of pregnancy.
But even in a sterilized female also, you can get ectopic.
Active.
Continue.
We did the USG, sir. USG was non-conclusive. The USG was saying that there was a query of free fluid.
Query
Query.
by the radiologist.
By radiologist. And
What about the VBG?
so we did the VBG, sir. VBG was showing a normal, no acid-base derangement, but she was having a lactate of 3 with the HB of 15.
Lactate of 3.
3.
Severe lactic acidosis can also happen in mesenteric ischemia. It's progressively worsening, unexplained abdominal pain. Because the ultrasound is not showing.
No
And the
other.
counts are all fine.
No, and ultrasound was asked.
Okay.
The lady was little obese. He was finding difficult to do the ultrasound, sir.
But for mesenteric ischemia, there should be some predisposing thing. Some clot should be, some patient is in having some infective endocarditis or something of that sort, AF and all. Patient may have a mesenteric. You should suspect. But it's a very rare diagnosis. Once in a blue moon only you'll get such things. All right. And there was on examination, there was not any tenderness, like no guarding or rigidity. It was just right iliac fossa pain.
Tenderness was there, sir.
The guarding rigidity.
Guarding rigidity as such.
If guarding rigidity is there, we should have thought.
Rigidity is not there, sir. But since pain is there, if you press, you will have guarding. A bit.
On the right iliac, you told it's in the right iliac fossa.
Right iliac, no, near the hypogastrium, around the umbilicus and epigastrium, sir.
Hypogastrium, umbilicus, and the epigastrium. Okay, guarding and rigidity is there. We should think about peritonitis.
It was not rigid, sir. It was soft.
Soft. Abdomen was soft.
At times, she would just guard if there is pain. She would not let us touch.
All right.
So we sent for the other investigation, including a beta HCG also, sir, because
urine beta HCG or
serum beta HCG was sent because she was not passing urine, sir. And we also went ahead with the plan for a CECT as suggested.
Beta HCG?
So our beta HCG came later on, and
later on, okay, you contribute.
And we went ahead with the further investigation and also beta HCG. So further investigations came out, like initial HB was 12, sir. Lab HB was 12 with the platelet count of 1.8 and total count of nearly 12,000, sir. Then other investigations including urea creatinine was normal. Urea was 11.6, creatinine was 0.68, sir. And also we did send the clotting parameters APTT PTNR, which was also normal. APTT of 26.2 and PTNR of 1.2, sir. And we also sent for the HBsAg HIV, the this test also came to be negative, sir. Because
Why was it sent?
we were also suspecting ectopic pregnancy. If at all it's ectopic, we had to do the pre-op surgery, sir.
As part of pre-op investigation.
Pre-op investigation. And also blood grouping and RH typing was also done, sir.
Why? What is the relevance of it?
For the same, sir. Surgery.
All right. There wasn't any HB fall as such.
Lab was 12, sir. Point of care 15, lab was 12. There was initially no HB fall, and
but he told ultrasound
free fluid.
He also told some query free fluid. Okay.
So we went ahead with the CT, sir.
All right.
By the time of we were sending for the CT. CCT. Her BP also came down to 90/60, but still was on the normal range, sir.
Okay.
So we went ahead with the CECT, sir, and CECT report came out to be a right adnexal mass of 9 into 8 into 10 centimeter with organized hematoma and active contrast extravasation into a mass near the right cornua close to the sterilization clip with hemoperitoneum, sir. And hemoperitoneum. And by that time she developed hypotension also, sir. So we started her initially on IV fluids, boluses.
So initially she was stable. After CECT she became unstable. So now it's your role. Now it's your turn to resuscitate.
Yes, sir. Initially we given IV fluid, bolus 30 ml per kg.
So now again you will have to go to the primary survey, the ABCD approach. Okay. Yes, so what all things you did?
So in the ABCD approach, airway, breathing.
A and B also was clear.
Clear, sir. In the circulation, but BP was initially 90/60 before sending, and after CT it went down to 90/50, sir. 90/50, and initially we started with the fluid bolus, sir. Right. So 30 ml per kg initial fluid bolus was given, but
30 ml per kg.
30 ml per kg. But also here BP was not picking up, sir.
Why 30 ml per kg?
Sepsis guidelines we can test.
But the patient was not in sepsis, right?
Not sepsis.
It's a hemorrhagic shock, right?
Hemorrhage.
It's not a septic shock.
No, sir.
Hemorrhagic shock means it should be giving the trauma 1 to 2 liters.
That will.
Till then, hemoglobin was this thing. After patient came back from CT, only we repeated another
HB,
which showed hemoglobin loss. Initial hemoglobin was.
So there was hemoglobin loss. So if blood is available, you can transfuse blood also.
Yes, sir. But we were not able to know whether blood loss is there or not, sir. Initial BP was on the lower side. We started with fluids. Okay. When we came to know it was hemoperitoneum and with the HB loss, HB dropped up to 9, then later on to 6, sir. So we started with massive transfusion protocol, sir.
Massive transfusion protocol means?
So we had to give PRBC, FFP and platelet at 1:1:1 ratio, sir. So followed.
When will you do massive transfusion protocol?
So either if patient is have lost blood of 150 ml per minute, or have lost 50% of blood over the past 3 hours, or have lost over the past 24 hours have lost sir more than how much? More than 50% of the blood, sir. Means 70 ml, more than 70 ml per kg of the blood over 24 hours.
That means patient will be in hypotension.
That
will be in hemorrhagic shock. When you do a massive transfusion protocol.
Yes, sir. Okay. And patient can have brady or tachycardia that time. And we have by the time our cross matching also came in, sir. That we could have arranged the same blood group for the patient, and
gynae was informed.
So when we got the report for the CECT, and by that time we got the report for beta HCG also, sir. Beta HCG came out to be 16,526.
Okay. So what is the relevance of beta HCG?
Beta HCG is a hormone which is produced by trophoblast, sir. That means trophoblast will which will get were implanted, and following by trophoblast will produce the beta HCG. If beta HCG is positive, it either can be of like a normal viable pregnancy, or else it can be of an ectopic pregnancy. So
how will we differentiate between?
For confirmation, we have to do the USG with the beta HCG.
Or
If
UC means
trans-abdominal or trans-vaginal we can do. At the ED we can do trans-abdominal. So if trans-abdominal is showing any viable intrauterine pregnancy with a traced beta HCG, that's a normal pregnancy. If there is no intrauterine pregnancy with a elevated beta HCG, that is suggestive of an ectopic pregnancy. Then there is the thing called discriminatory zones are in beta HCG.
in people who are on there is something called heterotopic pregnancy also.
Yeah.
You may see a viable pregnancy inside the thing. Patient who are trying on this thing, IVF and all. One this thing will be inside the uterus. Other one will be an ectopic pregnancy. So that's called heterotopic. There also you'll get similar
picture.
So you should be careful. All right.
Sir,
So where all ectopic pregnancy can happen?
So ectopic pregnancy as such outside the uterus.
Gynecology was informed by the time, right?
Yes, sir. Gynecology was informed. The ectopic pregnancy can be in the fallopian tube at multiple sites. Most commonly, it will be in the ampulla. That can be in isthmus or can be in the cornu. Then we can have intra-abdominal ectopic pregnancy, cervical ectopic pregnancy, or scar ectopic pregnancy also.
Previous history of surgery and all.
Scar ectopic.
Okay.
So that's the most common size, sir.
Okay, continue.
So then we got the report of the CCT and gynecology team was informed, sir. So we directly shift here to the OT for the same.
Okay, so tell me something about the beta HCG. What is the
beta HCG?
Which is better, serum or urine?
Serum beta HCG is better, sir, because serum will have more sensitivity specificity comparing with the urine beta HCG. Because if on comparing, like in serum it can have 10 nanogram, but by the same time in urine it will be like 1 nanogram only. So better sensitivity specificity will be for serum beta HCG. So it is better to.
Another issue with this thing is urine beta HCG. It may be hard to get urine also. If the patient is already lost considerable amount of blood, the patient is in hemorrhagic shock. By the time his bladder will be empty, there is nothing to. This much of hypotension, patient will not have urine, and that too. All these cases which come to the ER, usually they pass urine at home itself. So when they reach here, it is completely empty. You won't get anything to. No sample to do beta HCG. Okay.
So this beta HCG.
So any woman in the childbearing age, complaints of abdominal pain, amenorrhea, pain and bleeding, right? That is a triad. Suspect ectopic pregnancy. But here there wasn't any bleeding as
No bleeding as noted.
Bleeding was there.
No bleeding.
But it is not pervaginal. It's intra-abdominal bleeding was there. Got it, no? That's a patient went into hypotension. So this intra-abdominal bleeding can be because of other reasons also. What are things?
Other reason for intra-abdominal bleeding can be because of any intra-abdominal, sir, GA perforation.
Yeah, any gastro-related things will be there, and also ovarian-related, ovarian rupture and things like that. Cyst rupture, all these things can also cause fluid in the periton, and that usually that will cause some tenderness, guarding, and rigidity. That peritonism will be there. But in your case, it wasn't there. That is one thing which actually we probably whether it was a defect in the examination part, or I'm not sure about it. Obese patient probably would have missed that. Okay. So abdominal aortic aneurysm, those are the other things. GI surgery, aneurysm rupture and things like that can happen.
So other causes for bleeding in pregnancy as such can be miscarriage, then gestational trophoblastic
amenorrhea, pain and bleeding. So what are now we'll move on to the causes of bleeding in pregnancy. Okay, or non-pregnant female. Which one do you want?
Pregnancy.
Okay, pregnant female.
Then that can be miscarriage or gestational trophoblastic neoplasm. Then
commonest is normal menstrual
bleeding.
Then
miscarriage.
In a pregnant patient, yeah. Miscarriage, okay. Miscarriage, what all miscarriage?
Miscarriage can be a spontaneous threatened abortion, complete incomplete, then septic abortion or missed abortion, sir.
So up to what week you will say miscarriage?
Up to 23 weeks, sir.
23 weeks. Okay. It is also called abortion. Okay.
Then antepartum hemorrhage, that
After 24 weeks.
24 weeks.
It's called
Antepartum
antepartum hemorrhage.
So then other
Up till the delivery of the baby. All right.
then other lesions of genital tract, sir. Any polyps or any other lesions in the lower genital tract, including any chlamydia, herpes infection.
Polyp rupture and all. Okay.
Then any cancers of vulvovaginal cancers also can cause bleeding, sir. Then cervical cancer also can cause bleeding. Then the other things is ectopic pregnancy as such is a DD for
Okay.
and premature labor is also a DD, sir.
Premature labor. Okay.
Then placental abruptio placenta.
Abruptio placenta. Abruptio placenta means?
Premature separation of the placenta from the uterus
Okay.
because of shearing strain. So it causes bleeding.
Okay. Then?
Then will be the other
Placenta
causes
previa
like
will be
late causes, sir. Placenta previa, placenta accreta,
vasa previa.
vasa previa.
Previa is
Okay.
Then the bleeding in non-pregnant patients.
Non-pregnant patient, what are the?
So non-pregnant patient menstruation will be the most common thing. The other thing will be abnormal uterine bleeding. That can
Implantation bleeding.
implantation bleeding can be that is in pregnant patient. So then
Then what else?
then other things like coagulopathy, drugs can cause bleeding, sir. Anticonvulsants, then TCS, coagulants,
Tricyclic antidepressants.
OCPs, intrauterine device also.
Intrauterine IUDs.
IUDs can also cause. Then other ovarian dysfunctions can cause any PCOD can cause abnormal bleeding. Then endometrial disorders also can cause.
Endometrial. Cancer.
Cancer can cause
endometrial
bleeding.
Okay.
Then coagulopathy as such can cause.
Hypothalamo pituitary axis.
HPA axis suppression. HPA axis
can
action cause bleeding, sir. Then leiomyoma, adenomyosis can also.
Fibroid is the most common one. Non-pregnant female coming to you with bleeding, always think about fibroid, unless otherwise proved. Okay. Then adenomyosis. What is adenomyosis?
Abnormal uterine tissue outside uterus.
Outside? No, this endometrium. Endometrium tissue will grow inside the myometrium.
severe pain, causing
Severe pain. That's all the adenomyosis. Okay. Then?
That's normal.
These are the normal things which come to a thing. The other things are also there. Probably a gynecologist will be able to mention in detail about those things. So for us, the main thing is stabilizing, identifying
Cause.
whether like understanding what the causes of abdominal pain are, how to identify an ectopic pregnancy clinically, how to differentiate between the other GI causes or urological causes from gynae causes. And then if it is ectopic pregnancy, whether the patient is stable or unstable. If it is stable, you treat it in a supportive way, inform gynecology. If it is unstable, then control the C part, circulation part, massive transfusion protocol and things like that. If profuse bleeding and all is there, probably if gynae is not available on site, you can profuse bleeding, you can give some gauze or something.
Tampon
can be given, or else some Foley's can also be. In some textbooks, they insert the Foley's and inflate the bulb, and you give some traction and okay. Then tranexamic acid is also discussed in various things, and if the patient has got some underlying medical issues like von Willebrand factor deficiencies or platelet deficiencies, and all, correct those things also. Transfuse platelets. And if there is coagulopathy, give FFP vitamin K, things like that. That is what we should do. Anything more to discuss?
Mercy transfusion protocol as such we have discussed, sir.
This is actually a vast topic. You can't finish off in because it's a bleeding in a pregnant female and also in a non-pregnant female. You can get the details in the Arkham Learning, the website. Detail they have mentioned. Whatever is required from an emergency physician's perspective is written there. We are not talking in terms of a gynecologist. They have got their own priorities and their own way of managing. From our perspective, this is what we want to know, and handing over the patient at the right time to the gynecologist, giving a call to the gynecologist at the right time. Okay. And the other thing is, once if the patient is any patient coming with bleeding and all, whether the patient is pregnant or not pregnant. Second question. If it is pregnant and unstable, straight away to gynae. If it is not pregnant, the diagnosis will be based on focused on gastro things. Okay. So this is our take on
Ectopic.
ectopic pregnancy. Okay, that's all. Okay, thank you.